Rachel. I am from the University of KwaZulu-Natal in South Africa, and today I'm going to be presenting my research study, and the title is On the Knowledge and Practices of Healthcare Professionals in South Africa, on ototoxic hearing loss in children receiving platinum chemotherapeutic drugs. Okay, so the agenda today. So my presentation will cover the introduction, the methodology, the results, the discussion, and conclusion. So globally, cancer cases are expected to rise by 70% in the next 2 decades. Although childhood cancer survival rates reached about 80% in developed countries due to treatments like chemotherapy and radiotherapy, survival in many African regions remain about 30% due to limited access to screening and specialized care. So in South Africa, specialized oncology services exist within tertiary hospitals, but fewer than half of suspected childhood cancer cases are diagnosed, and many are identified at advanced stages. As a result, platinum-based chemotherapeutic drugs are required. So platinum-based chemotherapeutic drugs like your cisplatin, your carboplatin, and your oxaliplatin are widely used either individually or with other treatments to manage many malignant tumors. However, their effectiveness is accompanying a wider range of toxic side effects. These include your nephrotoxicity, your neurotoxicity, cardiotoxicity, gastrointestinal complications, and ototoxicity. Platinum-based ototoxicity typically presents as permanent bilateral high-frequency sensorineural hearing loss and tinnitus or tinnitus. Damage to hearing above 2000 Hz often impairs speech discrimination. Additional symptoms can include your hyperacusis, oral fullness, and vertigo or dizziness. So patients may view ototoxicity-related hearing loss as a major obstacle to daily functioning and overall quality of life, despite the significant benefits of cancer treatments. In children, even a mild hearing loss can interfere with the acquisition of speech-language skills. More severe high-frequency losses can disrupt speech perception and production, language development, intelligibility, and overall communication. So early hearing loss can slow language acquisition. So managing platinum-based ototoxicity requires a coordinated, So it requires a coordinated multidisciplinary effort involving audiology, oncology, physiotherapy, pharmacy, otolaryngology, nursing, occupational therapy, pediatrics, and psychology. So in children, ototoxicity management often differs from adult care, which can lead to miss or delayed detection and worsen the challenges associated with hearing loss. So Stratford et al. Found that children with ototoxic hearing loss experience low quality of life, particularly in aspects of communication, interdependence, and emotional well-being. However, with appropriate intervention, the severity of ototoxicity and its impact can be mitigated. With healthcare professionals treating children on platinum-based chemotherapy lack adequate knowledge and training, recognizing adverse drug reactions, the resulting consequences can be severe and irreversible. So the methodology of my study, the aims and objectives, which are to describe the perception and practices of healthcare professionals on ototoxic hearing loss in children receiving platinum-based chemotherapy. So that was the aim. And the are the objectives. To describe healthcare professionals' awareness of ototoxicity and the ototoxic effects of platinum-based drugs on the auditory system. To describe the practices of healthcare professionals in the ototoxic monitoring program for children. To describe the healthcare professionals' perception, the role of audiologists and that of other team members in the ototoxicity monitoring program for children. And lastly, to identify factors influencing the practice of healthcare professionals in an ototoxicity monitoring program for children. So the study design was a descriptive survey design was employed in the study, and the study was conducted at 2 public hospitals offering oncology services in KwaZulu-Natal, South Africa. The study population included ENTs, pediatricians, pediatric oncologists, audiologists, registered nurses, pharmacists, clinical psychologists, and physiotherapists. A total of 90 participants were needed to meet the requirement of a 95% confidence level, a 5% margin of error, and a 5% significance level. In this study, 74 healthcare professionals participated, resulting in an 82% response rate. So the data was collected using an anonymous self-administered questionnaire containing primarily closed-ended questions with a few open-ended items. The instrument included roughly 31 questions, which were divided into 5 sections. So the results which were obtained will be separated according to each objective. So objective 1, this graph reflects participants' knowledge of the symptoms associated with ototoxicity. 49 participants identified hearing loss, while 39 indicated tinnitus, and 19 indicated hyperacusis as a symptom of ototoxicity. This bar graph reflects participants' knowledge on the side effects of platinum-based chemotherapeutic drugs. And 45 participants recognized ototoxicity as a potential side effect of platinum-based chemotherapeutic drugs. However, only 8 and 25 participants indicated oral fullness and tinnitus, respectively, as side effects of platinum-based chemotherapy drugs. This graph reflects the participants' understanding of risk factors of ototoxicity caused by platinum-based chemotherapeutic drugs. 43 participants identified the dose, duration, and mode of administration as risk factors. However, it is worth knowing that 20 participants indicated not knowing the risk factors of ototoxic hearing loss as reflected in this figure here, or this graph rather. The next objective, which is objective 2, and this graph reflects the components of the ototoxicity monitoring program. And 20 participants, as seen in the figure, did not accurately identify all the components of an ototoxicity monitoring program. In comparison, only 3 participants knew that treatment adjustment based on changes in hearing was part of the ototoxicity monitoring program. So across professional groups, most participants accurately identified their roles within the program, but there were notable gaps. So all audiologists accurately identified most responsibilities, but one did not include raising awareness of ototoxic drugs, and the other incorrectly listed adjusting treatment regimens as part of their role. Most pharmacists who participated recognized their role in raising awareness about ototoxic medication, but only 7 identified suggesting otoprotective options as within their scope. All clinical psychologists correctly acknowledge their role in supporting patients' psychological well-being, though one did not include providing counseling to family members. Only half of the physiotherapists identified interprofessional vestibular rehabilitation as part of their responsibilities. All pediatricians accurately recognize their roles, including assessing comorbidities, initiating a treatment, inquiring about auditory symptoms, and referring for audiological assessments. Most ENT specialists who participated correctly identified asking about auditory symptoms and referring for audiological assessments, while 63.2% of the nurses recognized their role in monitoring ototoxic symptoms and making referrals. Fewer identified providing informational counseling, and some incorrectly included vestibular rehabilitation. And the pediatric oncologist all correctly identified their key responsibilities, which included assessing comorbidities, initiating treatment, requesting baseline assessment, reviewing treatment in response to ototoxicity, and inquiring about auditory symptoms. This table here reflects the overall knowledge scores on ototoxicity, which was divided into the different components which we assessed or looked into. And the next objective, which is objective 3, all audiologists reported performing ototoxicity, tympanometry, acoustic reflex testing, and pure tone audiometry at baseline and follow-up. However, only half conducted high-frequency audiometry. Most ENT specialists reported referring children for audiological assessment, and nearly all use an interprofessional approach when managing patients. Among nurses, 68.4% indicated making audiology referrals, with difficulty hearing being the most common symptom, while few recognize hypersensitivity to sound as an indicator. 1/3 of the occupational therapists referred patients for audiological assessment and used interprofessional collaboration. 40% of physiotherapists did not assess balance in children on platinum-based chemotherapy. Among clinical psychologists, half reported counseling families or caregivers, and most began counseling when emotional difficulties became evident. 2 psychologists used an interprofessional approach. Pharmacists showed limited involvement in patient education. Only 18.2% reported explaining ototoxic effects to families before treatment, and just 35.3% use interprofessional collaboration. The pediatric oncologist reported referring all children on platinum-based chemotherapy for audiological evaluation. Similarly, both the pediatricians who participated indicated that any child receiving platinum-based chemotherapy should be referred to an ototoxicity monitoring program, and both use an interprofessional approach. So the next few slides will reflect the results for objective 4. So this pie graph reflects the factors influencing the practice of healthcare professionals in managing children who present ototoxicity. So 14 healthcare professionals indicated that a lack of resources influenced their practices in managing ototoxicity in children. Other factors included the availability of a multidisciplinary team, time constraints, and a lack of knowledge of drugs and ototoxicity. The regression analysis conducted indicated that higher levels of knowledge were associated with improved practice performance, implying that knowledge may be an important predictor of practice-related outcomes. So our discussion includes, the current study found that although most participants had been educated in South Africa, more than 1/3 reported receiving no training on the ear, hearing, or ototoxicity. Over half felt that the training they had received were insufficient. These results indicated that many South African trained healthcare professionals felt underprepared to manage patients receiving ototoxic medication. Such feeling of inadequacy may have consequences for both practitioners and patients. Odlin et al. Noted that professional inadequacy can disrupt healthcare workers' sense of identity and alter how they perceive their roles and responsibilities. This gap in competency likely reflects an underlying educational gap and highlights the importance of strengthening academic preparation on platinum-based or platinum-induced ototoxicity before clinicians enter practice. Accordingly, undergraduate audiology programs and in-service training could incorporate more comprehensive content on ototoxicity. The findings indicate that in the absence of adequate undergraduate training in ototoxicity, many healthcare professionals rely on alternative educational avenues. More than half of the participants reported receiving training through in-service programs, postgraduate trainings, workplace orientation, or on-the-job learning. This highlights the role of supplemental training platforms in enhancing clinicians' ability to manage patients undergoing platinum-based chemotherapy. The inadequacy of existing education and training is further reflected in participants' knowledge of ototoxicity risk factors. Over a quarter reported being unsure whether risk factors existed for ototoxic hearing loss in children treated with platinum-based chemotherapy. Overall, participants demonstrated only moderate knowledge of these risk factors, suggesting uncertainty that is consistent with their reports of insufficient training. Given that awareness of risk factors and early symptoms are essential for identifying vulnerable patients and implementing timely management strategies, these gaps may hinder effective ototoxicity prevention and monitoring. In relation to participants' knowledge of symptoms associated with ototoxic hearing loss, 20.3% identified dizziness as a symptom, while just over half recognized tinnitus as an associated indicator. Overall, participants demonstrated only elementary level of knowledge of ototoxicity symptoms. A Kauting-based study reported that although 80% of oncologists had some understanding of chemotherapy-related auditory symptoms, 20% remained unaware of the symptomatology experienced by patients using ototoxic medication. Knowledge of ototoxic symptoms and risk factors are essential for early identification of children at risk for hearing loss, thereby enabling prompt detection and intervention. Early management is particularly critical in pediatric population as acquired hearing loss can negatively affect language development, emotional regulation, social engagement, and broader psychosocial outcomes. In this study, 60% of participants recognized ototoxicity as a side effect of platinum-based chemotherapy, whereas far fewer identified hyperacusis and oral fullness as potential outcomes. This limited awareness is notable given that hyperacusis is a debilitating condition often associated with medication-induced hearing loss. Overall, participants demonstrated only elementary level knowledge of side effects of ototoxicity, indicating a substantial gap in understanding. Comprehensive knowledge on the side effects and risk factors associated with platinum-based chemotherapy is essential for effective patient education during pre-treatment counseling and ongoing care. As such, information supports the early identification of ototoxicity. Importantly, early detection is within a multidisciplinary ototoxicity monitoring program, rather than the sole responsibility of the audiologist. In the study, 92% of participants acknowledged the critical role of audiologists in ototoxicity monitoring. Most respondents correctly identified the responsibilities of audiologists as well as other professionals within the monitoring team. Despite this generally positive outcomes of participants were unsure whether their hospital had an established ototoxicity monitoring program, which may contribute to limited number of referrals observed. This uncertainty underscores the need for strengthened training and education on the structure and implementation of ototoxicity monitoring programs. The study revealed notable gaps in participants' understanding of ototoxicity monitoring protocols. More than a quarter were unaware of the program's components. Overall, participants' knowledge of the program components were classified as not achieved. These findings are concerning given established guidelines. According to the HPCSA, children receiving platinum-based therapy require follow-up assessments at 3, 6, and 12 months post-treatment. Long-term monitoring is essential as delayed onset hearing loss may occur. The cisplatin can remain within the cochlea for up to 2 decades. Adherence to ototoxicity monitoring program is therefore critical for ensuring timely identification and management of hearing loss. Communication difficulties resulting from hearing loss can lead to long-term emotional challenges, including social isolation, loneliness, and depression. Families of children with hearing impaired also experience significant stress, financial strain, and communication difficulties. The current study identified several systemic challenges affecting the implementation of the ototoxicity monitoring program, particularly staff shortages and limited resources. Participants reported that insufficient staffing hindered effective service delivery, consistent with global projections of a 10 million healthcare professional deficit by 2023. In sub-Saharan Africa, human resource constraints are a major weakness, with fewer than 1 healthcare worker per 1,000 people compared to 10 per 1,000 in Europe. In South Africa, inequitable distribution of professionals within private and public sectors, as well as among provinces, exacerbating healthcare challenges. Poor working conditions and understaffing contribute to physical and psychosocial exhaustion among healthcare personnel. In addition, the study highlighted a lack of medical equipment and inadequate access to rehabilitation services, further constrained clinical practice, aligning with prior research demonstrating the negative impact of equipment shortages on patients, staff, and overall health system functionality. Financial limitations, insufficient human resource development, gaps in team members, knowledge of ototoxicity, poor communication among healthcare professionals, and limited training further impede the effective management of ototoxicity. These findings underscore the multifactorial barriers to optimal care in ototoxicity monitoring and the need for systemic interventions to strengthen workforce capacity, resources, and interprofessional collaboration. So the conclusion of the study included the findings of the present study reveal a clear relationship between healthcare professionals' knowledge and their practice in ototoxicity monitoring. This highlights the need to strengthen the knowledge base of professionals involved in pediatric oncology care to improve adherence to best practice. Education and training initiatives at facilities providing pediatric oncology service are essential to enhance healthcare professional competency in this area. Knowledge gaps were identified in several key areas, including recognition of hearing-related symptoms, awareness of the existence and components of the ototoxicity monitoring program, understanding the duration of monitoring, and proper implementation of HPCSA guidelines. Despite these gaps, participants demonstrated awareness of the critical role of audiologists within the monitoring program. However, small sample sizes within the professional groups limited the generalizability of findings, and the reliance on self-reported questionnaire data may have restricted the depth of insight. Further studies could benefit from qualitative methods such as focus groups or interviews to gain richer understanding. Clinically, the study underscores the need to review and enhance undergraduate curricula to include comprehensive training on ototoxicity, to implement regular structured training programs for healthcare professionals, and to ensure that oncology facilities have accessible resources for ototoxicity monitoring. Furthermore, the Department of Health could prioritize equitable distribution of resources, strengthen human resource capacity, and improve access to rehabilitation services. Further research could explore healthcare professionals' knowledge and practices regarding ototoxicity in children receiving platinum-based chemotherapy at a national level and assess the feasibility of implementing the HPCSA guidelines effectively. So these were the references that were used for the presentation. Thank you.
Overview. What is the nasal septal deviation and why is nasal septal deviation clinically important? Role of CT imaging in identifying anatomical variation, clinical impact, symptoms and complication, management, medical and surgical, brief summary of our CT patient finding in Benghazi, and final conclusion. Okay, anatomy of the nasal septum. Nasal septum located in the mid-sagittal plane, separated the left and right nasal cavity, and it is made up of both bone and cartilage. Bony part shown in the photo, perpendicular part, a plate of ethmoid. It has posterior portion and vomer and crest of the maxilla from the inferior and palatine bone. Okay, the nasal septum receives arterial supply from the splenopalatine artery and anterior ethmoidal artery and superior labial artery, which converge in Kesselbach plexus at a common sites of the nose bleeding or epistaxis. Cartilaginous parts is the from anterior and inferior portion. The septum separated the nasal cavity into passage and play role in airflow regulation and humidification and filtration, support of the nasal dorsum. Okay. In the aim, the proposed study is used CT scans to examine the structure difference in the nasal septum among adult Libyan in Benghazi. Object assess the prevalence of nasal septum anatomical variation in Libyan adult. Second, compare nasal septal variation between male and female to identify morphometric difference. Number 3, classify nasal septum deviation and abnormality using CT scan observation. In methodology, study design retrospective study using CT scan of the nasal region from Al Jala Teaching Hospital in Benghazi, sample 300 individual Libyan adult aged 8 years and older with CT scan from January 2025 to January 2026. Excluded criteria, excluded case with skull pathology or fracture, poor image quality, age below 8 years. and using anonymity. Okay, type of septal diffusion. Nasal septal diffusion present in several distant pattern, in six pattern. Number one, C-shaped diffusion. Number two, S-shaped diffusion, septal spore, and high diffusion, and low diffusion, posterior diffusion, and last complex or combined variation. CT help in identify direction of deviation and severity, involvement of bony or cartilaginous component. Okay, CT-based anatomical variation, study result, study population total participant 300 Libyan adult, gender disturbance male 65% and female 44%. Key finding most common deviation type C-shaped deviation, most frequent, S-shaped deviation, second most frequent, septal spore commonly association with deviation. Additional finding commonly affected region mid-septal diffusion was the most prevalent, like in this photo. Number one, it has mild diffusion. Uh, when classifying nasal septal diffusion according to angle, uh, we uh, uh, we 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 uh, we we classify the type of the diffusion three type: mild and moderate and severe. Mild from the 5 to the 12, moderate above the 12 to the 50. Above the 50 it has severe, like in the photo it has to the left sides mild, and in below photo it has to the right sides it has moderate. Okay. So, okay, commonly affected region mid-septal diffusion was the most prevalent. Laterally right side diffusion was light, more common than left. Age association, no statistically scientific correlation between diffusion severity and age. Okay, clinical impact of nasal septal diffusion, nasal obstruction, primary symptoms affected airflow, mouth breathing, compensatory breathing pattern, sleep disturbance and snoring, disturbed sleep quality, recurrent sinusitis, impaired sinus drainage, headache and facial pressure, chronic discomfort because it has highly contraction, and lastly, epistaxis or nose bleeding, less common complication reduced quality of due to chronic nasal airflow limitation. Symptoms and complications. Symptoms of nasal septal diffusion: nasal blockage and obstruction, difficulty breathing, especially during exercise because is increase of the contraction, mouth breathing, snoring, hyposemia, reduced smell, persistent nasal dryness. In complication, recurrent sinusitis, frequent headache, sleep disturbance, turbinate hypertrophy, chronic mucosal inflammation, in rare case, septal ulceration or crusting. How to diagnosis of nasal septal diffusion. First one, anterior rhinoscopy, first line examination in clinic, nasal endoscopy identifies poor posterior diffusion, mucosal condition. Number three, CT image, gold standards for evaluation type of diffusion, severity, anatomical variation, and associated sinus disease. Symptoms assessment tool, nose score, and VAS. Medical management. Medical management focus on symptoms relief and association condition. Number one, topical nasal corticosteroid spray, reduced inflammation and improve breathing, not treatment. Saline irrigation, improve mucociliary clearance. Short-term decongestant, use with caution to avoid rebound condition. Antihistamine indicated in allergic patient or in allergic case. Treatment of association condition, address rhinitis or sinusitis. We show important note, medical therapy does not correct the deviation itself, but it reduces inflammation and help the patient breathe better. Indication for surgical management, persistent symptoms despite adequate medical therapy. scientific airway obstruction, recurrent sinusitis associated with deviation, severe anatomical deviation seen on CT scan, deviation interfering with endoscopic sinus surgery. Surgical option, septoplasty most commonly performed procedure for nasal septal deviation, correct deviation by riptostuning or rasping the septum while preferring structure support can be combined with turbinant reducent if needed. Number two, submucosal resection SMR, older but still used technique, remove deviated portion of cartilage and bone, useful in severe deviation but carries high risk of septal perfusion compared to modern septoplasty. Number three, endoscopic septoplasty, like in the right photo, minimally invasive approach allowing excellent visualizing of posterior deviation, preferred when deviation is complex or association with sinus pathology, offer reduced bleeding and faster recovery. Number four and last, combined procedure, septoplasty plus troponate reduction or septoplasty plus functional endoscopic sinus surgery when sinus disease coexists. In conclusion, nasal septal deviation is a common anatomical condition with scientific impact on nasal airflow and overall quality of life. CT image provide accurate identification of deviation type and association anatomical variation, making it essential for surgical planning. In our CT patient study of 300 Libyan adults, the most common deviation were C-shaped, followed by S-shaped and septal spore variation. Mid-septal deviation was the most prevalent pattern, with no scientific correlation between severity and age, proper diagnosis and individual's management, whether medical or surgical, improving patient outcome sufficiently. Nasal septal deviation remain condition where clinical evaluation plus CT finding together guide optimal treatment decision. And this is reference, and thank you for listening. I would be pleased to address any question or engaging in discussion. Thank you.
Thank you, Doctor.
Namaste. So I'm Dr. Amulya and I work at JSIS Academy of Higher Education and Research, Mysore, Karnataka, India. So my topic for today is steroid-eluting nasal implants in rhinology. Evidence synthesis 2010 to 2015. Next slide. Please change the slide. Next slide, please. Caroline, please change the slide.
Just a moment, we'll check and share your screen.
Yeah. As I say next, please change the slide. Yeah. So the objectives of my presentation today is, firstly, the evolution and mechanism of steroid implants. Second, evidence synthesis. That is 40 studies, including RCTs, observational studies, and in vitro studies, clinical outcomes and safety profile, real world impact and cost effectiveness, evidence-based recommendations, and future research directions. Please change the slide. Now coming to steroid-eluting implants. So bioabsorbable PLGA polymer matrix contains the matrix of polymer which is bioabsorbable. There are various materials like PLA, many other materials, but the most suitable material and most commonly used material is PLGA. After many researchers, they found that the best steroid that can be used is mometasone. So the They have used 370 microgram of steroid, and which has shown a drug release of for 30 days. So that this kind of steroid eluting stent has dual roles, that is mechanical stenting and local anti-inflammatory deliveries. The FDA devices are Propel, which is being used in the ethmoid sinus, Propel Mini for the frontal sinus, and Sinova, which is also used for the ethmoid sinus. And this Sinova can be implanted in the office. So it is a daycare procedure. Please go to the next slide. Yeah, coming. So initially in 2011, the first FDA approval stent came out. That was for the ethmoidal sinus. That was the Propel. It was developed in the United States. Next, in 2014, they came up with a stent for the frontal sinus, for the frontal recess. That was called Propel Mini. So all of these are still not being commercially used in large numbers. Next, in 2017, they expanded for endoscopic sinus surgery as indications of various reasons, maybe for recurrences as such. Then in 2022, they released an implant called the Sinova. So we took up various studies, various RCTs, observational studies, and we did a meta-analysis. So this is the Prisma flowchart for the same. So we took a number of studies and then we screened and we took the best studies which we got, the complete studies, and then we studied them. So this is the Prisma flowchart for the same. Please change the slide. Coming to the mechanism of action. So basically there's implant deployment. So the stent, which is a bioabsorbable material, contains mometasone furoate, which is released in 30 days. So this releases the inflammation, the edema, and and prevents adhesion and synechia. So apart from this, it also maintains the sinus patency. So what happens is the drug is in the polymer matrix and it is released slowly and consistently. And as it is released, there is also mucosal healing. Please go to the next slide. Now, based on our meta-analysis, these are the outcomes which we came across. First, the post-operative pain. In the you can see the VAS scores. VAS score is for the pain and it is out of 10. You can see here that with implant it has reduced significantly. With implant it was only 2.1 plus or minus 0.8, whereas for non-steroid it was 5.8 plus or minus 1.1. So there was 64% reduction. So based on 6 RCTs, we confirmed that it was a better. It was superior to the non-steroid implant. Please go to the next slide. Coming to mucosal healing and edema, there was significant improvement. So in all these studies, they had studied the mucosa over 1 to 3 months, and they saw that the mucosal edema reduced to, there was only 12% mucosal edema in implants, whereas there was 38% in the control. This says that there is faster epithelialization and reduced crusting and bleeding with the stent. Please go to the next slide. Coming to the synechia and adhesion formation, it's studied in this, they have seen that the synechia rates is significantly reduced and it's only 5 to 10%, whereas in controls it was 20 to 30%. So the relative risk was only 0.42%. Go to the next slide. Now studying the polyp recurrence and the revision surgery, they studied 12-month outcomes and they found that the polyp recurrence was significantly reduced. So P value was less than 0.001. So there has been a greatest benefit in CRS with nasal polyposis. Please go to the next slide. Now, patient reported outcomes. Coming to the SNOT score. So there was a significant reduction in that. No score also showed a significant improvement. And there was reduced in need for systemic steroids. Hence, there was an improved quality of life. Please go to the next slide. Coming to the safety profile, so there was reduced in the adverse effects. Incidence of infection was 3%, transient edema was 6%, and device extrusion was less than 2%. Hence, there were no serious complications. Please go to the next slide. Now, coming to the real world evidence of 24 months. So, in the where in a place where there are most of them are working professions and people do not have time to visit the doctor repeatedly, I would suggest that steroid eluting stents is the best option. That's because it reduces the post-operative visits, the need for oral steroid courses. So when you're not taking oral steroid courses, then you're not leading to any of the side effects of the oral steroid courses, and reduce antibiotic use. Hence, this resulted in cost effectiveness. Please go to the next slide. Coming to the current indication, this is level 1 evidence that it can be used in postoperative endoscopic sinus surgery for the ethmoidal cavity. Frontal recess surgeries, you can use Propel Mini, and you need to select the right cases. In case of CRS with nasal polyposis, in high risk recurrence, that has benefited a lot. And Sinova has been used in office polyp revision cases, but in limited. If it is limited to the ethmoidal sinus and it is minimal, then you can use the office-based Sinova. Please go to the next slide. Now, though the steroid eluting stent has a lot of benefit, there are some limitations. Device heterogeneity, short follow-up, that is only for 24 months. So we do not know what happens after that. Industry sponsorship bias. We do not have lot of sponsorship from the companies, and in a country like ours, which is still a developing country, things are really in a research phase because these are very expensive and not available in our countries. So we are still working on that and trying to develop our own indigenous stents. And we have limited data about pediatric cases. Not much stents have been developed for pediatric cases. And the cost effectiveness variability, in the sense that the stent is costly, but everything else, the expense for everything else is cut down because there are no lesser post-operative visits. You're not taking oral steroids, you're not taking antibiotics, so all that cost is reduced. But so we are trying to develop indigenous stents in India. Please go to the next slide. Next slide. Coming to the future research priorities. So we need to develop long-term multicentric RCTs, and we need to compare head-to-head because we do not have many stents to compare and standardize. We need to standardize the outcomes because these have not been being used commercially and regularly for surgeries. We are still in the naive in the initial stages. So, and we also need to do the cost-effective analysis and also develop novel steroid formulations, which we are doing and working on. So to make it more cost effective. Please go to the next slide. Now coming to the clinical recommendations. So routinely you can use it for high risk endoscopic sinus surgery patients. You can use Propel Mini for standard, Propel Mini standard for frontal sinus cases, and it can be used in CRS with nasal polyposis in revision cases to prevent recurrences. But you should be very careful when selecting the patients because they need to be compatible with the stents, and they should be compliant, and you should be compliant to use it for 30 days. So, and we need to monitor the 30-day post placement, and if they do not come for follow-up to look for the placement, then it's going to be difficult. Please go to the next slide. So here the key takeaway messages is that steroid eluting nasal stents have been proven to have short-term benefits, excellent safety profile, reduces healthcare burden, It's an emerging standard of care, but we need long-term data. So if we develop indigenous, cost-effective stents, then that is going to make a real difference for all the ESS patients. Next slide. Thank you, everyone. If you have any doubts, you can contact me. This is my email.
I'd like to uh, speak about the role of using propolis supportive therapy. I'm a senior AI and ML researcher and pharmacognosy expert, and I'm working on as a dynamic leader in AI-driven pharmacognosy with more 10 years bridging a traditional ethnomedicine and modern ML for drug discovery. I have PhD in ancient creator of ethnomed advisor, the project with the Google generative AI capstone 2022, 25, sorry. And I have many awards, gold medal in INA and ARCA and the WIBO Global Figures Award. About the traditional healing properties of bee propolis,
Sorry for the
honeybees create
interruption.
propolis by collecting.
Your screen is not visible now. Could you please check it?
It's okay? It's okay?
No, it's not.
What's the problem? I'm sharing my presentation. It's visible for you?
Yes, it's visible now.
Okay. Honeybees create propolis by collecting resin from the tea bark and leaf buds. This resin formed to protect buds from fungi and diseases are chewed mixed with enzyme and beeswax and used in the hive. Ancient Egyptian working on using the propolis for keeping the body of the human body, and propolis means in Greek, ancient Greek, front the city or the city shield. One beehive produce about 25 to 30 kilogram of honey and sugar, so that there is must be a substance injurious, so that the propolis is this a very important substance to keep away the infection from this hive. Propolis ramps the immune response in honeybees infected with bacteria. The social immunity is a key factor for honeybee health, including behavior defense strategies such as the collective use of antimicrobial plant cuisine. A study in China found about 5,000 local beekeepers possible due to propolis use. Further control laboratory studies are needed to confirm propolis role in preventing viral and bacterial infection. So that our goal in this study to development a green extraction method and using it to as an antibacterial side by side with the antibiotic, because the resistance of antibiotic, especially in the respiratory tract infection in our country, it's huge. And according to UN SDGs, to use a green chemistry by extracting the propolis from the bee honey. So that we did this study and make from the raw propolis powder dissolution and then make a study about the efficacy, and then underscored the propolis potential as natural supporter in treating bacterial infection. Propolis collection as chemical analysis and free radical scavenging activities show us that the bacterial isolates used in this study were obtained from clinical samples at Aleppo University, and the standard antibiotic used in a study there is many antibiotic, vancomycin, ampicillin, augmentin, and chloramphenicol, ciprofloxacin, zithromycin, gentamicin, and cifbin. Propolis was collected from the northwest countryside of Masyaf in the western area in the Syria, and using the vinegar water extract to determination the total phenolic content and the flavonoids. Then the antibacterial efficacy was tested against certain pathogenic bacteria, comparing with the standard antibiotic by using a Kirby-Pyre method on Staphylococcus epidermis, Aureus, and Pseudomonas aeruginosa, and E. coli. Here we find the 5 basic phenolic compounds were identified in the studied extract of Syrian propolis, and there is 8 essential organic compounds, fatty acids, sterol, and terpenes were identified in the studied extract of Syrian propolis. This slide shows a total phenolic comparing with garlic acid standard series. The percentage of total phenol in the extract was calculated term and was 299.31 milligram. Antioxidant activity, the DBPH assay is 74.89 percent. Here we find the antimicrobial activity of the aqueous vinegar propolis extract, where the diameter of bacteria inhibition zone was recorded in millimeter, and the anti and there is 3 replicates with the results show us that diameter of the inhibition holes range from 18 to 20 millimeter towards gram-positive bacteria, and 12 to 17 millimeter toward gram-negative bacteria, as we've seen for the pathogenic bacteria. The antimicrobial activity of this extract is higher in relation to gram-positive than gram-negative bacteria, and there is many of bacteria has resistance to the antibiotics used as a standard antibiotics. The antibacterial efficacy of this extract against Staphylococcus aureus is comparable to that of imitamab, and vancomycin against Staphylococcus epidermis is similar to vancomycin, and selected antibiotics against E. coli in according to chloramphenicol, and against Pseudomonas aeruginosa exceed most antibiotics, except imitab and ciprofloxacin and gentamicin. The extract, both of the extract has many components than the aquatic and the ethanolic extract, comparing extraction method. And here the structure of the chemical composition which lead to the antibiotic efficacy, so that the study also highlighted the richness of Syrian propolis in phenolic content and its importance to a natural antioxidant, making it a key component for enhancing human health and treating diseases. The organic propolis extract showed greater antibacterial activity against gram-positive bacteria compared to gram-negative bacteria, and compared to the anti-chemical profile of propolis extract show us that the absence of several components in the ethanolic extract suggests that the our extraction method it's better than the using of alcohol in preparing the extract, and we develop a green extraction method. Then we take a patent about our extraction method and make a healthy functional food with propolis considered as antioxidant and supporter the antibiotic or using it for immunity, so that we have to use the functional food with natural potential antibiotic to make the resistance lower than by using this natural extraction. Thank you very much for your time, and I'm ready to any question. Do you hear me?